Good evening and welcome to Myositis Support and Understanding. My name is Jerry Williams. Today we are honored to have Kevin Dooley, a retired ophthalmologist and inclusion body myositis patient, who is able to use his medical background to help us better understand and explain IBM during this patient-led education session. Today he'll be talking to us about the NT5C1A antibody and its role in diagnosing IBM. Kevin, thank you so much for taking the time to be with us, and welcome.
First of all, I'd like to thank you, Jerry, and MSU for providing these opportunities. You give us a great opportunity to talk to each other through the support groups, and these video conferences are another way that we can learn from each other, and I really appreciate it.
Thank you. It's our pleasure.
I'd like to emphasize that although I am a doctor, I'm speaking today as a patient. I was diagnosed with IBM in 2016. And before I learned that I have IBM, I'd never heard of IBM. So I'm by no means a myositis expert. Having said that, being a doctor is helpful because my medical background allows me to understand the medical side of things better than if I weren't a doctor, obviously. So today's presentation is given from my position as a patient who's kind of educated myself as best I can about this topic. One thing that I've done is to create a website that provides education about the disease. It's called Cure IBM. And if you haven't seen it yet, I'd encourage you to take a look because you might find it useful. It's at cureibm.org, and you can find it on Google. And aside from the website, I have a blog, a Facebook page, and a Twitter account. Today we're going to be talking about this NT5C1A Antibody Test. That sounds a little complicated, you know, NT5C1A, what does that mean? What is the antibody test? The discovery of this, the discovery of the antibody and the commercialization of the test for the antibody has been one of the major advances in IBM medical research in the last several years. Doctors are always looking for ways to improve diagnoses to make it easier and more accurate. This test was developed with the large help of Dr. Steve Greenberg. Some of you might know him or know of him. He's an inclusion body myositis researcher at Harvard, and he gets a substantial amount of the credit for this test. So I'd like to thank him for what he's done for us in developing this test. It's easy to forget what happened in the past with medicine and how far we've come. This test is one step in the progress of learning more about IBM. I'd like to step back for a minute to talk about a different example of medical progress from my own experience and connect that with this antibody test. My medical education, if you will, actually started the year before I went to medical school. I wasn't thinking of being a doctor when I was in college. I didn't get that idea till later. And at that point, it sounded good in theory, but I'd never been in a hospital much or worked with sick people, so I got a job in a hospital radiology department. This was back in 1978, and the hospital was all excited because they just purchased their first CT scanner. Today, it's hard to look back and realize how marvelous that CT scan seemed at the time. To put it in perspective, I'll tell you a little story. In the room next to the CT scanner, we had a room for a procedure called pneumoencephalography. Pneumo refers to air, encephalo refers to brain, and graphy refers to picture. So basically it meant air-brain picture. In those days, you couldn't learn too much about a brain from an x-ray because the brain matter all looked the same on an x-ray. So doctors used to drain some of the fluid from around the spinal cord, inject air or some other gas that would then float up to the skull And then they take x-rays, and the air would be able to outline different structures to see if there was a brain tumor or something. They would strap the patient to a table and have the patient with head up, head down, tilted to the left, upside down, all kinds of places so the air would float to the top. It's pretty bizarre by modern standards. So now we have CT scans and MRI scans, and they make the diagnosis of many, many diseases much easier. Well, getting back to IBM and this antibody test, the discovery of this antibody test is somewhat similar. It's a small thing. It's nowhere near as big as inventing a CT scan, but it illustrates the same kind of progress, and it makes the same type of changes in IBM diagnosis, just on a smaller scale. That's just in my lifetime that we've had this imaging change, and I'd like to think a little bit during this talk about what can happen in the next decade or 20 years for IBM. And with IBM, doctors don't inject air to go into our skulls, but doctors do muscle biopsies, and muscle biopsies are an invasive procedure. You have to have surgery. It's not a huge deal, but if you've been diagnosed with IBM, you've probably had a chunk of your muscle removed, maybe even twice. The antibody test does not replace muscle biopsies, at least most of the time, but it's a little step in that direction. So I'd kind of like to get you excited about this test. When you have IBM and there isn't any effective treatment, and you hear about a clinical trial and then it fails, and another clinical trial and it fails, it's easy to get discouraged and feel like, hey, doctors don't get this disease, they're not making any progress. This antibody test is a sign of progress. And it's progress that has already benefited IBM patients and hopefully will benefit us more in the future. So I'd like to talk briefly about how IBM is diagnosed in general. First of all, there's the symptoms: weakness of muscles and special patterns. Often hand grip is weak, legs are weak, people fall, can't get up from low chairs. Most of you know a lot about the other symptoms. Then you go to a doctor and they do a physical examination. The doctor should test the strength of your muscles and look for atrophy where the muscles have shrunk. Blood tests can be helpful, and that's what we're mostly going to talk about today. Electromyograms can be helpful, where the test measures electrical activity in the muscles. MRI can be helpful. It's not always done, but sometimes it can help diagnose the disease, and it can help guide the muscle biopsy. And then the main way the diagnosis has been confirmed is with a muscle biopsy. Muscle biopsies are considered the gold standard, but they're not a muscle biopsy is not a perfect test. First of all, it's invasive, like we've already talked about, but also it's not 100% accurate. Sometimes you could have a negative biopsy because you're perhaps too early in the disease course. If they came back later and did the biopsy several years in the future, maybe it would be positive. On the other hand, sometimes the biopsy is done too late, where the normal or almost normal muscle has been replaced by scar tissue or fat, and there isn't enough in the way of classic features to guide the pathologist who looks at the biopsy specimen. IBM can be patchy, not just in which muscle it attacks first, but where in the muscle. And if you had bad luck and they took the biopsy from a section that didn't contain typical findings, the biopsy might not show the disease. And finally, IBM patients vary from one to another. We're not all the same. And some people probably never do show all the classic findings on biopsy of IBM. If you have IBM, but the biopsy doesn't show clear features of it, you could be misdiagnosed. And this has been a significant problem. A lot of people are diagnosed with polymyositis because the doctor relies too much on the muscle biopsy. Since the muscle biopsy is the gold standard, if the muscle biopsy doesn't show rim vacuoles and other characteristic findings, doctors have often said, oh, I guess they don't have IBM, maybe they have polymyositis. So there's a trend nowadays to be a little less reliant on the biopsy and to take clinical features more into account. For example, the finger weakness that's typical of IBM is pretty common in IBM, and it's quite rare in polymyositis. And so doctors have to pay attention to things like finger weakness and not rely completely on the muscle biopsy. There's two kinds of blood tests now that can help: creatine kinase or this antibody test. Creatine kinase doesn't tell you if you have IBM, but it can be a clue that you have a muscle disease as opposed to, say, a nerve disease or something else. Creatine kinase, often called CK, is an enzyme that leaks into the blood if your muscle cells are damaged. So in the presence of muscle disease, the levels will be high. The antibody test, on the other hand, is specific for IBM pretty much. A positive antibody test can say, not only do you have a muscle disease, but you have IBM. Before we get into the details of this antibody, I'd like to talk about antibodies in general. Antibodies are part of the immune system, and the immune system is basically our body's defense system. Antibodies are protein molecules that circulate in the blood. You can think of them as these little microscopic particles, zillions of them, that go all throughout our body looking for invaders like bacteria and viruses. This is a schematic diagram of an antibody. There's 4 protein chains. The orange ones are called heavy chains. The blue ones are light chains, and they're hooked up as it shows in the diagram. So it kind of is shaped like a Y. And at the tip of the 2 arms of the Y, there's a certain shape there, if you look at it microscopically, that can match up with what's called an antigen, a protein, for example, on a bacteria. It's like a lock and key where the 2 can fit together. In this diagram, on the left, you could pretend that that circular large structure is a bacteria. And on the surface of the bacteria, there's different molecules that project. Some in this diagram are like a circle, triangle, and square. And then it shows these 3 antibodies floating around. And at the tip of the Y, the shape on the antibody is made to match the shape of the molecule on the surface of the bacteria. So on the right-hand side of the diagram, it shows when the antibodies have attached. Now, when the antibodies attach, they don't necessarily kill the bacteria. They more like tag it. It lets your body know, hey, this is a bad guy. We got to do something about it. And it activates other parts of the immune system. The diagrams I've shown already are pretty simple. This is an artist's attempt to show what an antibody looks like more in real life. The blue part are those heavy chains, and the tan part are the light chains. Even this is pretty simplified, but it gives you a little more of an idea. And I don't know if you can see my mouse, but at the tip of the Y, there's little projections and crevices and so forth. If you could magnify this even more, there'd be enormous variety on the surface of the antibody in terms of the shape there. Because you want to have an antibody for each possible invader. Scientists have estimated that you need to have about 100 million different antibodies, because that's how many proteins or molecules you'd want to identify on viruses, bacteria, parasites, things like that. They think we only have about 20,000 genes in our body, so how you get 100 million antibodies is pretty amazing. It's a little complicated and involves different segments of genes being reshuffled and combined with each other. The guy who figured this out got the Nobel Prize, but it's one of the wonders of how our bodies work. In this diagram, it shows that blood cells come from stem cells in the bone marrow. And all these cells at the bottom are different types of white blood cells. On the left, there's a category called lymphocytes, and that includes B cells and T cells. T cells are also involved in inclusion body myositis, but they don't have anything to do with antibodies directly. So it's the B cells that are involved in making antibodies. Now, if you're going to have 100 million different types of antibodies, and they all come from their own category of B cells, which are also called B lymphocytes, it would be complicated to have lots of B lymphocytes for every kind of antibody you want to make. So it turns out you don't have very many at all. But if you have an infection, they get turned on, and your body makes more and more of that particular kind of B lymphocyte. This diagram shows a B lymphocyte with an antibody, basically an antibody sticking out of its surface. And if the bad guy comes and interacts with the tip of the antibody, it stimulates that B cell to multiply and divide and make more B lymphocytes just like itself. And to give you an idea of the scale of these, each B lymphocyte has about 100,000 of these little antibodies sticking out of the surface. So going back to that previous diagram, down below where it says B cell progenitor on the left, you have plasma cells and memory cells. The plasma cells develop after the process I just talked about. Plasma cells are basically antibody factories. They just make lots and lots and lots of them. I think I read that they can make 2,000 antibodies per second when they're activated. When the infection's all gone, your body doesn't want to keep all those plasma cells forever, so most of them die off. But you have these things called memory cells that are in the diagram there. They stick around, and they're ready for the next time. If you get infected with the same organism, the memory cells are ready to kick in gear. The process speeds along faster than it would have the first time you had the infection. That's how vaccines work. Basically, you get the antigen injected into you. If your body makes antibodies, the memory cells stick around and help protect you the next time you're exposed to the disease-causing agent. Now, that's antibodies in general, but some antibodies do not protect us. They actually can harm us, and those are called autoantibodies. These autoantibodies react with your body's own tissues. You're really not supposed to have these antibodies. It's the whole process when your body makes these B cells. You don't want to have B cells making antibodies that attack your own body. So your body has a way to get rid of those B cells. But sometimes things slip through the cracks, and it happens. And this is one of the ways you can get autoimmune disease. Disease is where your body attacks itself, kind of like rheumatoid arthritis, polymyositis is a good example, lupus, and so on. And IBM kind of fits into that realm to some degree anyway. So now I'd like to talk about this NT5C1A antibody, which you might call the IBM antibody, because there's only one antibody that's been strongly associated with IBM. That abbreviation NT5C1A comes from the full name of the molecule that the antibody attacks. And that molecule is called cytosolic 5' nucleotidase 1A. It's quite a mouthful, so you can see how it's abbreviated. Sometimes you'll see it abbreviated as just simply CN1A. And in the red, it shows you where the CN1A comes from. Most of the time I've seen it as NT5C1A. It's a little more complicated, but if you rearrange the red numbers and letters, you can see where the NT5C1A comes from. So what is cytosolic 5' nucleotidase 1A? Turns out it's an enzyme in the body. It's in all of our cells, and there's a lot of it in muscle cells. But nobody really knows why IBM patients can get an antibody to this molecule. It's kind of a mystery that's being researched. So this test now, the test for the antibody to see if it's in your body, how good is it? One way doctors and researchers measure this is called sensitivity. Let's say you have 100 people and they all have the disease, and you give them the blood test. What percentage of those people who do have the disease will have a positive test? Turns out for this antibody test, it's only about 50%. So half the time, if you have IBM, the test will be negative. And in that case, it's not very useful. The other side of the coin, though, is specificity. This is defined usually in a way that's a little counterintuitive, but it's basically if you had 100 people who don't have IBM, how many times will the test be negative? And it's about 95% for this antibody test. So what this means is if you do have a positive test, there's a very high chance you actually have the disease. That's kind of the take-home message. If you are suspected of having IBM and have a negative test, you haven't really learned very much. But if the test is positive, you probably have IBM. Now, it turns out that this antibody is sometimes found in other populations, not just IBM patients. But in none of these situations is it as common as it is in IBM. Lupus, Sjogren's syndrome. Sjogren's syndrome is an autoimmune disease where people get dry eye and dry mouth. And dermatomyositis, depending on the study, might have 10, 15, 20% of the people could have a positive antibody test. In terms of diagnosing IBM, that's not as bad as you think, though, because if you're a patient in a doctor's office and you have symptoms of IBM and you don't have symptoms of these other diseases, then the fact that 10 or 15% of those patients can be positive doesn't have too much effect on you. Normal, healthy adults rarely have a positive antibody test, but some recent studies have shown that normal, healthy children, to some degree, can have a positive antibody test. There's some problems with this test, and you have to keep in mind that it's a new test. I'm not sure exactly when it became commercially available, but it was somewhere like 3 years ago. First thing is there isn't any standard laboratory technique for getting your results. In other words, if a lab gets a vial of blood and they want to say, hey, does this blood have this antibody in it? There's more than one way they can find out. And different labs use different techniques, which might affect how sensitive the test is or how accurate it is. And then when they do get the results, there's no standard way to report the results. Even if two labs use the same test, they might report it differently. And I'll get into that more in a minute. To illustrate this, I'll talk about the two labs that I'm aware of in the United States that do this antibody test. I don't know which labs overseas do the test, but the same principles would apply. Washington University in St. Louis has a really great neuromuscular department, and they have a lab there for blood testing. They use something called the Western blot technique. And when the result comes back from the WashU neuromuscular lab, the result is reported as either positive or negative. Either you have the antibody or you don't. That's all there is. There's another lab called RDL Reference Laboratory based in the Los Angeles area, and they use a different technique called ELISA. When they report their results, there's a number, and they give you this range you can see on the screen, where less than 20 basically means you don't have the antibody, 20 to 39 is weakly positive, 40 to 80 is moderately positive, and greater than 80 is strongly positive. So sometimes patients talk among themselves, and it's confusing because somebody will say, I had a result of 75. What'd you get? It's like, well, mine just said positive. Well, it could be they got the results done in different laboratories. I'd like to talk now about the usefulness of the test. When is it useful? When is it not useful? Can it ever replace a muscle biopsy? And I'll do this by going through some fictional cases I made up just to illustrate some points. So let's start off with a man who's 78, who everything seems typical of IBM. His symptoms, his pattern of muscle weakness, his EMG, but the muscle biopsy does not show definite IBM. He could be one of these people who's misdiagnosed as having polymyositis. But now he could have this antibody test, and if it's positive, makes a pretty strong case that he actually does have IBM in spite of the either negative or equivocal muscle biopsy. So that's a practical, real-life situation where the antibody test is useful already. Now let's take another patient who's just the same, except in this case, the muscle biopsy does show all the classic signs of IBM. At this point, let's say the patient was diagnosed 5 years ago before the antibody test existed. Is there any reason to get an antibody test? Probably not. He's already been firmly diagnosed with IBM. If the antibody test is negative, it isn't going to change your mind. If it's positive, this confirms what you already know. The one exception could be for research purposes. If this patient has seen an IBM specialist who does research, the specialist might want to get this test just to help understand the disease some more. So this third case, let's say this patient is suspicious for IBM, but it's not quite typical. Fingers are normal, fingers are weak in the way that they usually are in IBM, but the quadriceps muscles in the thigh are relatively strong. The CK blood test is pretty high for IBM. Now, it still could be IBM at that level, but it's not quite as typical. And the patient has a positive antibody test. Should you do a muscle biopsy? Probably yes, because it's not classic, and just the fact that you have a positive antibody test probably is not enough to avoid recommending a muscle biopsy. In this case, I'm talking about somewhat of a contraindication to a muscle biopsy. Everything's typical, but the patient had a heart attack before and had a coronary artery stent and takes aspirin every day. Aspirin makes you bleed more. It helps prevent the blood from clotting as well, so this man's coronary arteries will stay open. But that's a problem if you have a muscle biopsy, because you don't want to have a whole lot of bleeding when you cut into a muscle. If you take an aspirin, it makes you bleed more than average for at least a week. So it's a little complicated if you want to do a muscle biopsy. In this case, with the typical clinical story and the positive antibody test, might be quite reasonable just to skip the muscle biopsy and not do it. This is a similar situation. There isn't actually any contraindication to a muscle biopsy, but maybe there isn't a strong reason to do it. If everything's typical and the antibody test is positive, the person probably does have IBM. And this particular patient I've illustrated doesn't have the desire to be in a clinical trial. That's a point I want to make, because to be in a clinical trial for a drug to treat IBM, most trials are going to require you to have a muscle biopsy. They want to know as much as they can about the patients in the trial. So if you want to be in a trial, you probably have to have a muscle biopsy. So to kind of sum up the diagnosis angle here, the antibody test can help make the diagnosis of IBM, but it's not always necessary nowadays. Now I should clarify that those cases and my analysis of them are my opinion of the situation in general. But individual doctors and individual IBM specialists might have their own take on when they want to do things. So just keep that in mind, that medicine's not an exact science. And if you see a doctor, they might have reasons that I haven't talked about or thought of for when to do which test. But a positive antibody test can reduce the need for a muscle biopsy, or maybe eliminate it in some situations. Now, even though this talk is sort of titled The Antibody Test and Its Role in Diagnosis, the antibody test has some uses besides diagnosis. And one of the obvious things is, if half of the IBM patients are positive for this antibody and half aren't, is there something else different about those patients? Are they in different subgroups of the disease? Do they come down with the disease at different ages? Do they have different muscle groups that are primarily affected? There's lots of questions like that. And one question that's already been looked at somewhat is, does a positive antibody test affect your prognosis? If you have a positive antibody test, does that tell us anything about how quickly you're going to get worse compared to somebody else? It turns out that we have conflicting information so far, and there isn't a complete answer. There are some studies that seem to indicate that people with positive antibody do worse than people who don't. But there's some other studies that don't show that. And none of these studies are prospective. In no case have they had two groups of people, one positive and one negative, and followed them for 10 years to see what happens. So we don't really have an answer on that completely yet. Another question is, would having this antibody affect treatment? Right now there isn't any treatment, but as new treatment is looked at, they're going to be looking at this question. If you have a clinical trial for a drug for IBM, the researchers are going to want to know, do people with positive antibody tests respond differently than those who don't? In the arimoclomol trial that's just starting, I believe all the patients are being tested for the antibody for this kind of reason. The antibody test is useful also just for research about the disease. Things we have to work on are standardizing the test, and that's not only just to diagnose patients, but also for research. Because you do a research study and it shows that 44% of this kind of patient are positive. Now another similar study says, no, it's not 44%, it's 30%. If they did the test differently, you don't know how to compare exactly. So as time goes by and doctors know more about this test, it'll probably get standardized more. And then the question is, does this antibody cause the disease or worsen the disease? Now, first thought, you might think, well, how could it cause the disease if half the people with the disease don't have the antibody? But there could be different subgroups, and theoretically, in some of those people, this antibody might be involved in initiating the disease. But regardless, if you actually have the disease, maybe the antibody worsens it because the antibody attacks this molecule that's exposed. And finally, the antibody can be used as a tool to teach us about the disease. Now, as researchers study a disease, in the beginning, they don't know what to start with hardly. You know, they have to have clues as to where to look and tools to use. Now that they know this antibody exists, in trying to learn about the antibody, they can learn about IBM in general. Like people who are positive for the antibody, why? What happens to let them be positive? For one example, antibodies generally don't go inside cells. They're floating around in the blood and they're outside cells. And so they might not recognize the antigen, the molecule they bind with, if that molecule is inside a cell. But in IBM, the muscle cells are dying and the inside contents of the cell can be exposed to the bloodstream. And maybe that's what triggers this antibody to develop and recognize this molecule that's normally inside the cell. But again, why does it do that in some people and not others? And what does this molecule do? That cytosolic 5' nucleotidase 1A, is that somehow involved in the disease? There's some preliminary work on this, and it seems like it might be involved with how our cells handle proteins. And problems with protein folding and protein clumping and recycling of these protein clumps seems to be a big part of IBM. And this molecule that the antibody reacts with might be involved in that somehow. So all these things are things that are being worked on in research labs and are an important part of the progress that this antibody is leading to, in addition to just diagnosing whether somebody has IBM or not. That's all that I have prepared. I'd like to thank Myositis Support and Understanding again, and Jerry for hosting this session. And I'd like to open things up for questions.
Thank you so much, Kevin. Really appreciate all that great information. And the whole time I'm thinking, this is kind of where the art of medicine comes into play. And, living with a rare disease and being, involved in so many different aspects of a rare disease, I don't think a lot of patients get that, the art part of the medicine. Why doesn't my doctor know this? And why don't they have, if this is this, then they should give me that. Or, and there's a lot of, like you talked about, it's just a lot of different aspects where, there's no clear guideline. You just have to kind of take the information that you're provided with and then make your best educated guess and kind of go for, I hate to use the word guess, but your best scientific guess, I should say. But it's interesting. And the fact that you started out with the part about, how it can seem very frustrating and like nothing is being done. Since my time at MSU, 3 years now, I've seen so many wonderful things that are happening in the myositis community. So, everybody that doesn't feel like there's anything being done for IBM, any other type of myositis, there are so many things that are in the works. So keep the hope. There's a lot of stuff going on. Thank you all again for joining us today for this live video education session. Remember, this was a patient-led session. Always discuss your concerns with your physician and healthcare team. Learn more about myositis support and understanding and inclusion body myositis at understandingmyositis.org.